welcome to our continuation of our Advisory Council on Alzheimer's Research Care Services and Risk Reduction. So we're thrilled again to be gathered today. And as we talked about during this morning session, we're really glad to have a session that started us out with talking about comprehensive care models, how we can provide care for persons living with dementia and families, supporting them, engaging them in the process, but also thinking about healthcare systems, community engagement as well, and how this can be paid for. So thank you for those of you who presented and took good questions and comments that made after that session. And again, as we move into this next session, we're talking about a new phase of Alzheimer's care that we haven't had discussions on before, because we haven't had drugs that have been for other than the therapies we use for symptomatic control in our clinical practice previously. So as we mentioned this morning when we started out this discussion, again, this will be a part of our comprehensive care living with dementia and their families. And so there are a lot of different agencies and groups that have input into how these medications are studied, how they're approved, and how they get into clinical practice. So today, for our next discussion, we are very grateful to have 3 agencies who can present to us and teach us as an advisory council more about the processes that are related to FDA approval, both the accelerated approval of medications, the process that the Department of Veterans Affairs does for drug approval, and also recognize that FDA provides care, and also for the Centers for Medicare and Medicaid Services, CMS, to talk about their processes as well. So again, as we mentioned at the beginning, all of us are here because we care very much about Alzheimer's disease, people living with the disease, advances in therapy, advances in care. So we appreciate that. So we look forward to having a good discussion following these presentations. And again, this section is to help us as advisory council members to learn more about the processes and more discussions, deliberations in our subcommittees and this group. So, with that, again, afterwards we will ask some questions tonight that will be available for the advisory council members. Again, those of us in the room and those of us online who are not part of the council, we have the option through public comments, but we will not be allowed to ask questions during the session, the discussion. So with that, we'll go ahead and get started. So we thank you so much for those of you who are attending online for our speakers. So we'll start with our first presentation by Dr. Teresa Baracchio, from the Food and Drug Administration, and she will be talking about therapies in Alzheimer's disease, the approval process, and implementing scientific discoveries and advances in aging health. Dr. Baracchio, welcome.
Hi, good afternoon. I'm Teresa Baracchio. I'm the Deputy Director and current Acting Director of the Office of Neuroscience in the Center for Drug Evaluation and Research, or CDER, at FDA. Today, I'll provide a brief overview of the approval process, the FDA regulatory pathways for drug approval, and how these have been used in recent approvals for therapies for Alzheimer's disease. And I'll also briefly describe how FDA incorporates evolving scientific knowledge into our drug reviews. And we can go to the next slide. Okay, so traditional approval, which is also referred to as full approval sometimes, is the usual approval pathway for most drug development programs. Traditional approval requires that substantial evidence of effectiveness be demonstrated on a clinically meaningful endpoint. This is often defined as an endpoint that directly measures how a patient feels, functions, or survives. I'll also note that a validated surrogate endpoint can also be used for traditional approval, and this is an endpoint that has strong and established evidence for its ability to predict clinical benefit, and I'll explain that concept further in a subsequent slide. It's also important to note that for all approval pathways, the drug must be demonstrated to be safe for use under the conditions prescribed or recommended in the proposed labeling. We can go to the next slide to discuss accelerated approval. So accelerated approval is a particular type of approval that FDA may grant for a product for a serious or life-threatening disease or condition. And the ability to use this pathway takes into account the unmet need in the disease, such as the severity of the condition and the adequacy of available therapies or the lack of available therapies. Accelerated approval requires the demonstration of substantial evidence of effectiveness that the product has an effect on an endpoint that is not itself a direct measure of clinical benefit of interest, but is instead reasonably likely to predict that clinical benefit. It is also subject to the requirement that the applicant study the drug further to verify and describe its clinical benefit. The use of the accelerated approval pathway allows for the acceptance of some uncertainty with the use of a reasonably likely endpoint. However, it is crucial to recognize that the evidentiary standards for effectiveness are not lower for endpoints used to support accelerated approval than for traditional approval. Substantial evidence of effectiveness on those endpoints is still required. Accelerated approval really concerns the character of the endpoint. An effect on an endpoint supporting accelerated approval must be an effect on the endpoint that in its character is reasonably likely to predict clinical benefit, and in its persuasiveness provides substantial evidence of effectiveness from adequate and well-controlled trials. So we can move to the next slide. I have described the use of surrogate endpoints in the previous slide, so I'll take a minute to explain the difference between a validated surrogate endpoint and a reasonably likely surrogate endpoint. As I mentioned earlier, a surrogate endpoint is an endpoint that is used in clinical trials as a substitute for a direct measure of how a patient feels, functions, and survives. A validated surrogate is an endpoint supported by a clear mechanistic rationale and clinical data that provides strong evidence that an effect on the surrogate endpoint predicts a clinical benefit. Therefore, because it is established, it can be used to support traditional approval without the need for additional efficacy information. And some examples of validated surrogates are hemoglobin A1C, which has been used for the approval of drugs intended to treat diabetes mellitus, and blood pressure reduction, which has been demonstrated to predict reduction in rates of stroke, MI, and mortality. And it has been used as the basis for the approval of drugs in pivotal trials of for drugs and medical devices intended to treat hypertension. A reasonably likely surrogate is an endpoint supported by clear mechanistic and or epidemiologic rationale, but there is insufficient clinical data to support its use as a validated surrogate endpoint. These endpoints can be used for accelerated approval for drugs or expedited access for medical devices. In the neurology divisions in CEDAR, reasonably likely surrogate endpoints have been used to support accelerated approvals in Duchenne muscular dystrophy based on increased dystrophin levels on muscle biopsy, and in Alzheimer's disease based on reduction of amyloid plaques on positron emission tomography or PET. We can go to the next slide. So in the prior slides, I described the difference between traditional and accelerated approval, that this is really distinguished by the character of the study endpoints and whether they measure clinical benefit directly or indirectly. However, I will now discuss the regulatory standards for effectiveness to support approval under either pathway. You've heard me mention several times this phrase, substantial evidence of effectiveness, and that is a legal standard that must be met in order for drug approval. And this standard applies to drugs for all diseases. Substantial evidence of effectiveness refers to both the quantity and quality of the data that is submitted to support an approval. Substantial evidence is defined in Section 505D of the Food, Drug, and Cosmetic Act, which I've copied here, the exact language, but I'll summarize that it is basically evidence coming from adequate and well-controlled investigations that, when evaluated by experts qualified by scientific training and experience to evaluate the effectiveness of the drug, can be fairly and responsibly concluded that the drug will have the effect it purports or is represented to have in the proposed labeling. Next slide. It has long been the FDA's position that Congress generally intended to require at least 2 adequate and well-controlled studies, each convincing on its own to establish effectiveness. And this usual requirement for more than 1 adequate and well-controlled investigation reflects the need for independent substantiation of experimental results. Independent substantiation of a favorable result protects against the possibility that a chance occurrence in a single study will lead to an erroneous conclusion that a treatment is effective. Although 2 adequate and well-controlled clinical investigations are the usual standard for generating substantial evidence of effectiveness in many disease settings, there are scenarios in which a single trial can be used to establish effectiveness. Reliance on a single trial alone may be considered to establish effectiveness in situations in which the trial has demonstrated a clinically meaningful and statistically very persuasive effect on a clinically meaningful benefit, and confirmation of the result in a second trial would be impracticable or unethical. In other words, we're able to rely on the evidence from a single trial in isolation when it provides evidence that is similarly persuasive to that which might result from 2 separate trials taken together. Typically, a single study approval would be based on a large multi-center study which shows robust and statistically very persuasive statistical findings with consistent effects observed across multiple endpoints and study subgroups. And then on the last bullet, under certain circumstances, FDA can also conclude that 1 adequate and well-controlled clinical investigation of conventional persuasiveness plus confirmatory evidence is sufficient to establish effectiveness. In this situation, the confirmatory evidence would serve to provide the independent substantiation of the results of the single study. This approach may be considered in severe or rare diseases with high unmet need, and the ability to use this approach will depend on the persuasiveness of the single trial and the robustness of the confirmatory evidence. We can go to the next slide. So regulatory flexibility is a term that we use often, but is challenging to define. Our regulations allow for and encourage the use of regulatory flexibility to expedite the development, evaluation, and marketing of new therapies that are intended to treat persons with life-threatening and severely debilitating illnesses, especially where there's no satisfactory alternative therapy. I've selected a few quotes from our regulations and guidances below to illustrate this point. These quotes demonstrate FDA's recognition that the benefits of the drug need to be evaluated in light of the severity of the disease being treated, and that some degree of uncertainty regarding a drug's effectiveness may be acceptable when balanced against the risk of rejecting or delaying the marketing of an effective therapy for an unmet medical need. And we can go to the next slide. So I've mentioned the regulatory concept of unmet medical need several times here, and unmet medical need refers to a condition whose treatment is not addressed adequately by available therapy. We do consider that Alzheimer's disease does have unmet medical need. Alzheimer's disease is a serious and devastating disease. Although there are approved therapies, Alzheimer's disease remains progressive and fatal despite these available therapies. And FDA recognizes the urgent need for safe and effective therapies for Alzheimer's. So the next slide, our recent drug approvals in Alzheimer's disease provide examples of the use of the accelerated approval pathway and some of the regulatory concepts that I've described. In June 7th of 2021, aducanumab, a monoclonal antibody that targets aggregated amyloid, received accelerated approval based on reduction of amyloid beta plaques on amyloid PET imaging, a surrogate endpoint that was determined to be reasonably likely to predict clinical benefit. A clinical trial to confirm clinical benefit has been initiated. Go to the next slide. Earlier this year, another monoclonal antibody that targets aggregated amyloid, lecanemab, received accelerated approval based on the same surrogate endpoint. A phase 3 trial to verify the clinical benefit of lecanemab has been completed and has been submitted to the FDA for review. I will note that this application will be discussed at an upcoming public advisory committee meeting that is currently scheduled for June 9th. We can go to the next slide. I'll now pivot to a brief discussion of how the FDA incorporates scientific advances into regulatory review. Our neurologists and neuroscientists at the FDA stay up to date with current published medical literature. However, our stakeholder engagement is really a key source of our learning about the scientific advances that are being made in Alzheimer's and other neurologic diseases. Some examples of our engagement activities are listed here, but are not limited to these. We try to actively participate in meetings as much as our schedules allow. Some of the meetings that we do participate with, especially in the Alzheimer's disease space, is we attend to scientific meetings like the Alzheimer's Association International Conference and the Clinical Trials in Alzheimer's Disease meetings. We are part of working groups in Alzheimer's disease. We engage in public-private partnerships such as CPATH and their CPAD consortium. We participate in research roundtables, and although I don't think Alzheimer's disease specifically has had many of these, we do find these useful for a number of our neurologic diseases, which are patient-focused drug development meetings where patients can have an opportunity to share their patient experiences and what they would find to be a clinically meaningful benefit in clinical trials and the challenges that they face in enrolling in clinical trials. We are also engaged in pre-competitive initiatives for data sharing and tools for drug development, such as clinical trial simulation tools. You can go to the next slide. And I'll also note that we have a number of FDA regulatory science efforts within the agency through which we can engage with industry and the scientific community. I'm not going to go through this list in detail, but more information on these programs can be found on the FDA website. And the next slide will be my final slide. So we are able to implement our learnings about scientific advances in the advice we provide back to sponsors of investigational new drug applications, or INDs, during drug development. Sponsors are able to request formal meetings with the review divisions under their INDs to discuss their drug development programs, and we provide direct feedback during those meetings that often and always really incorporates the scientific learnings and recent scientific knowledge that we've gained. We also review submissions to INDs, such as protocols and statistical analysis plans, and provide feedback to sponsors on those submissions. We also strive to incorporate the latest scientific information into our reviews of new drug or biologic licensing applications, which is, an example of what we did with aducanumab and lecanemab. There are also other ways that we can publicly endorse scientific advances, such as through qualification efforts for biomarkers and clinical outcomes assessments for a specific context of use. And finally, the agency can issue guidances that describe the agency's interpretation of policy on specific regulatory issues. Notably, we do have a draft guidance on the development of drugs for early Alzheimer's disease, which can be updated as the scientific knowledge about the disease evolves. And I will stop here. Thank you very much.
Who's our acting director of our coverage and analysis group. And importantly, just want to also take the opportunity to just emphasize, the distinction and clarify what folks may have heard through public vehicles, some of the press, and that CMS may be challenging the authority of FDA. And that is not the case. In fact, any work that we have been doing has been in close coordination with the FDA. So, Teresa, thank you so much for the collaboration, and to our ASBE and CDC, ARC, all of our colleagues, our federal colleagues here. Importantly, to say that CMS will make Medicare national coverage decisions that are based on a authority that is distinct from the FDA's authority. That is, whether an item or service is reasonable and necessary for the treatment of an illness or injury. And we generally review the information as it is applicable to the Medicare population. So with that, if we could have the next slide, please. And Helen, thank you for controlling the slides. So just to make this point, what I'm illustrating here is a snapshot of the 2021 fee-for-service population of Medicare beneficiaries. And just to walk through it a bit, the portion of the population that has just a single condition, with the single conditions laid out on the y-axis, that single condition, or the population with just that one condition, appears in dark blue or indigo, if you prefer. And we have a line that is dedicated to Alzheimer's and other dementias. Importantly, that population is about 5% of the Medicare population. So as you move to the right of the slide, we illustrate the proportion of the Medicare population that has one or two other conditions, which is in yellow, 3 or 4 other conditions, which is in white or beige, and those who have 5 or more other conditions appears in aqua, which is so that is more than 50%, about 55 or 54%. So, as we interpret the words about reasonable and necessary applicable to the Medicare population, it's really important that this is the population who we keep at the forefront of our minds. With that, I will turn this over to Dr. Chin to take us through the other slides, and also to provide some examples of how we apply these authorities. Joe?
Thank you, Sherry, and thank you, the committee, for really inviting us to speak. Could we go to the next slide, please? So I'll provide just some basic background in addition to what Dr. Ling just presented, really how we approach item services is set by the Social Security Act.
Joe, we're losing your audio.
Your audio.
Let me try to. Is this better?
So have you keep talking, it kind of went in and out.
Okay, I'll try to speak a little louder and closer to the phone. I hope it's better. If not, please let me know. I'll try to alternate this. So Medicare is really authority to cover items and services that set forth the Title 8 of the Social Security Act. We refer Medicare as a defined benefit program. So there are a number of benefit categories that are established by the Social Security Act that an item and service needs to fall within for Medicare to actually consider coverage. And for example, these are typically performed by the Center for Medicare when looking at benefit categories. And some of the larger benefit categories are, for example, inpatient hospital services, outpatient services, physician services are a large group, durable medical equipment, and then, of course, drugs and biologicals. So those are some of the categories that a certain item or service needs to fall within for Medicare to then consider, whether we could be able to cover the item and service. And particularly from our standpoint of Medicare coverage, the one part of the statute that really sets forth the way we approach the review is Section 1862A1, which is set in the negative. So we generally, for simplicity, say that in Medicare, as Sherry mentioned earlier, Medicare covers items and services that are reasonable and necessary for the diagnosis and treatment of illness and injury. And that's really the general approach we use for all the types of items and services that we may be asked to look at that fall within these categories. For example, physician services, surgical services, durable medical equipment, certain implantable devices. They're all within that same consideration. May we go to the next slide, please? So, Medicare to provide coverage of an item or item and service. The national coverage determinations are reduces in central office. In the absence of a national coverage determination, the Medicare local contractors may determine coverage of certain items and services either through a local coverage determination or through a claim-by-claim adjudication process, which may involve case reviews. So from our standpoint, in our group, in our coverage analysis group, we are the group that is responsible for developing the national coverage determinations. And the process that we go through to develop the NCDs, as we call them, is defined in statute. So there's a statutory timeline that we need to meet once we open a national coverage assessment. Now,
Joe, we lost you on statute.
Okay, opportunities for public comment in our process. As our staff in our coverage analysis group reviews the evidence to make a determination whether an item and service is reasonable and necessary under Medicare, we will look at all the published evidence, which includes peer-reviewed journals and professional society guidelines, for example, materials that actually have been vetted in the public. In our determinations, when we actually determine an item of service may be reasonable and is reasonable and necessary, for example, we may include what we call various implementation factors. This is that really helps explain and describe circumstances of how Medicare will cover a certain item of service. And for example, there are a number of patient characteristics, for example, that may be included. As Sherry mentioned, typically, these treatments are for a certain condition, and the patient characteristics and specific conditions themselves will be described, pretty clearly in the decision. Also, as appropriate, we will include provider criteria. For example, the types of physicians that may provide a certain service or other providers. And sometimes we also will include facility criteria that looks at which facilities and what type of performance experience that they provide these types of services. I think all this is in our national coverage determinations and also in the decision memo that's associated with the NCD. And I think if you look through some of the national coverage determinations that we have developed over the years, you also get a sense of really how we approach the evidence review and how we actually determine which of the criteria to include into a specific NCD. And I think we have a lot of experience with certain cardiac devices, and by looking at those decisions, I think that can provide a general understanding of really how we would approach any particular type of item or service. And in those types of procedures, for example, the transcatheter, repair, replacement types of procedures, we did outline, very specifically, what, patient characteristics need to be met to be under those coverages. For example, what type of condition, and actually, what type of heart failure and how severe the heart failure would be. We also included various, requirements for the cardiac surgeons or the interventional cardiologists that may be actually providing these transcatheter types of treatments, and also the facility requirements for some of the facilities so that they actually can perform these type of procedures with the outcomes that have been really set forth and described in the clinical trials for these types of procedures and devices. So I think in general that's a very broad description of the process that we actually will undergo for any particular type of NCD that we conduct, and be happy to try to answer questions later on thank you.
Thank you, Dr. Chin. I think they're having some trouble hearing us from the other microphone, so we'll be moving on to our third presentation by Dr. Jennifer Martin from the Department of Veterans Affairs, talking about policy prescribing for lecanemab and plans for future implementation, challenges and opportunities. So welcome, Dr. Martin. I think you just got off your flight, so I hope that went well. Thank you for joining us for this important discussion today.
No problem. And yes, I literally walked in 15 minutes ago from the airport, so bear with me. Next slide, please. I think before we talk about the VA's decision about monoclonal antibodies for Alzheimer's, it's really important to understand what the VA system is, because I think it's very different than the private sector or even CMS in terms of how we function. Essentially, VA is a staff model HMO. What's great about this model for our purposes is that it allows VA to very quickly institute changes, whether they're formulary changes, maybe we find a safety concern with a particular medication, we can literally stop use right away, and we can enforce those changes throughout our system. And the reason that we have that flexibility is that we are a comprehensive health system, so all of our benefits are integrated. The pharmacy benefit is part of the overall package. We are a direct provider of all care for our veterans. Our providers are our employees, so they have to follow the rules that we put in place. And we own and operate our own infrastructure. So really, when we make a decision, it's very easy to implement across the system. Next slide, please. So we have the same process for review of all new molecular entities from the FDA. Once the new molecular entity is approved, our team does a literature search. They put together a drug monograph in most cases, and any accompanying clinical information we think we might need to ensure safe and effective use within our system. Once those documents are drafted, they're presented to a small group within our National Formulary Committee, and they get an initial round of edits. The next step is really crucial for our system. All of our documents are disseminated widely to clinical staff practicing in the area of interest in the field, and we take their comments. We leave our comment period open about 2 weeks, and we actually do review all of the comments and incorporate those. I think this step is very different in what's done in PBMs in the private sector. And I think it's very important to help us get staff buy-in for the formulary decisions that we make, because we are hearing from the providers that are out seeing the patients. Once we get those comments back, the draft comes back to our national formulary for review. We talk about the comments, we make any changes that we think are appropriate, and then we make a national formulary decision. I want to just make a few general comments about the VA National Formulary that are important to understand. First and foremost, all drugs are available within the VA. all drugs are covered. We don't have anything in our statute that allows us to say we aren't covering a drug at all. So whether a drug is on formulary or non-formulary, it's still covered. So it's not synonymous with the private sector. If a drug is in a non-formulary status, that essentially means that the provider needs to provide some sort of clinical justification through the electronic health record to show why they want to use that particular medication. Usually we only deem drugs non-formulary if there are questions about safety or efficacy, or if it's a case where there's, 4 or 5 drugs in a class and we're trying to really drive use one way or the other due to some kind of contracting determination. The National Committee determines whether or not we develop criteria for use to help guide the safe and effective use of the drug within the field. And then once those national decisions are made, they're disseminated to our local medical centers for implementation. Once we make a decision nationally about formulary or prescribing criteria, the facility must follow the national position that's approved. They are not allowed to tweak that. They're not allowed to change the criteria. Next slide, please. So I want to focus on the drug class that's really relevant for this particular meeting today, and that's really the monoclonal antibodies for Alzheimer's disease. So far we have aducanumab and lecanemab that are approved. I think part of the reason that I was asked to talk about this is that there's very misleading press releases and media coverage, depending what you were reading out there, that outline the VA status. And it's caused a lot of stakeholder confusion for us, both internally and externally. So I'm here today to set the record straight. In the media, the VA decision has often been portrayed to be radically different than how CMS is handling this class. But in fact, once I describe it, you'll see that the decision is really aligned. We're just managing it in a slightly different way. And the reason that we can do that is because we are a closed system, like I described on the first slide. Next slide, please. So both aducanumab and lecanemab really have the same formulary status. They are both considered non-formulary. The only difference, and really, I think it was just a difference in the time that we did the review, there's not really a meaningful difference in terms of how we would operationalize these, is that aducanumab doesn't have a standalone criteria for use. Instead, the criteria are embedded in the drug monograph in a place in therapy section, and I hyperlinked here in case you're interested in reviewing that. All of our documents are publicly posted. For lecanemab, although it's also non-formulary, it has a freestanding criteria for use document. And again, operationally, the same thing would happen in the field for either drug. If there was a provider who had a patient that they thought was appropriate, they would enter a non-formulary request in the electronic health record. They would look at those criteria and give supporting information to show that the patient meets all the inclusion criteria and then they don't have any of the exclusion criteria. That request is reviewed by someone at the local medical center level within 96 hours and adjudicated, either as approved or does not meet guidance. Just to put it in perspective, in general, if you look across all non-formularies, somewhere between 83 and 85% are approved. So it's a very small proportion that are not approved. And again, I think that's because we get the provider buy-in for our criteria, so they know what the criteria are before prescribing. In addition, because both of these drugs have moved through that accelerated approval pathway that Teresa mentioned, and we do have some questions about safety and clinical effectiveness, a prospective medication use evaluation is required for each dose of drug administered. So at baseline and with each administration. And really, this is how VA operationalizes coverage with evidence. So very similar to the CMS decision in this class, except we're able to do this internally and not require clinical trial enrollment. And the whole purpose of doing this is to assess safety and appropriateness of use for any patient started on these agents. And in a few slides from now, I'll give you a glimpse of the types of information that we're tracking. We also recognized very early on that these drugs needed a lot of local infrastructure in place. And I'll talk about that at the very end of my presentation. But we wanted our sites to look at our VA-specific guidance and figure out internally how to coordinate those resources. And we didn't want interference from the outside, from folks who may not understand the VA guidance fully or may not understand some of the limitations with resources. So both of these drugs were voted to be non-promotable within VA, which essentially means the sales teams from the manufacturers can't come in and promote. We've done this with other drug classes in the past where, it's really a lot of coordination that's needed to safely administer the drugs. And then we review that list every 6 months or so. And once we're at the point where we feel like the bulk of our facilities have that infrastructure in place, we will remove that restriction. But it just seemed like now we needed to give our sites some time to settle and figure out how to safely infuse. Next slide, please. So I want to just say that this is not all inclusive in terms of the inclusion criteria for aducanumab and lecanemab, but I really tried to take some of the commonalities between the two. If you take the time to review our documents, what you'll see is that they very, very closely align with the clinical trial data available to date that supported the approval of these drugs. We do require that the prescriber must be a VA neurologist, a geriatric psychiatrist, or a geriatrician who specializes in treating dementia. We also require that they are internal VA providers. So we are not leaving this open so that our community care network providers can prescribe. And really, safety is the emphasis of that decision. I told you on the previous slide that we had made a decision to launch the prospective medication use evaluation. And unfortunately, the way our community care network contract is written, there is not a way to enforce that with community care providers. So we felt that we would be offering our patients two different standards of care. If the patients that were treated internally had additional safety screening and the patients that were treated outside were not. So we chose to only allow internal infusion of these drugs. The patients, very consistent with the label, must meet criteria for mild cognitive impairment or mild Alzheimer's disease. That has to be supported with amyloid PET imaging or CSF analysis, again, with findings consistent for Alzheimer's. We do require some baseline screening with either the FAST, MMSE, or an equivalent scale. Again, just confirming that diagnosis because it is difficult to diagnose Alzheimer's disease definitively, and we want to make sure they are in the mild stages. We also require that neuroradiology is available to review the serial MRI scans, and I'll talk in a couple slides about why that is a limitation for some of our sites. Next slide, please. So again, these are not all of the exclusion criteria, but some of the commonalities between the two drugs. So obviously, if it's any condition other than Alzheimer's that may be contributing to the cognitive impairment, we probably would elect not to start those patients on these drugs. They need to be able to have brain MRIs. So if they have a contraindication, they are not considered candidates. Patients who've had a transient ischemic attack, stroke, or seizure within the past year are not considered candidates. If they've got baseline MRI abnormalities related to edema or hemorrhages, we would not consider them candidates at this time. And then we're also screening for patients with untreated bleeding disorders. So not all patients with bleeding disorders, but those that are untreated or unmanaged. Next slide, please. So I know this is a busy slide, but it just gives you a glimpse into what our real-time prospective MUE looks like and what it's assessing. So again, the goal is to assess safe and appropriateness of use of the agents in this class. So the first step is that we want to make sure the patients are appropriate and the providers are appropriate. So we have the providers confirm their specialty and that they're allowable to administer based on our criteria for use. We have the provider confirm the appropriate patient diagnosis. We have built in a criterion that the facility needs to confirm that there's a standard operating procedure in place for patient infusion and monitoring. And when I get towards the end of my presentation, I'll explain that and why we felt that it was very important. We have the provider confirm that the patient meets the inclusion and does not meet any of the exclusion criteria prior to administration. We track and monitor the infusion itself and the dosing that's given, and also any concomitant therapies that the patient receives. We track and monitor safety, specifically focusing on adverse drug events during infusion and in between doses. Those go into our internal tracking system, which is called VADERS, and then they would be sent to the FDA MedWatch system from there. We have some questions just as a general efficacy assessment, but again, that really isn't the goal of this MUE. It's the safety and appropriateness of use we're focusing on. And then we are planning to track and assess reasons for discontinuation of therapy. Ongoing monitoring and reports will be reported to our SMEs in this area and also our national formulary group. And again, going back to the closed system and the flexibility that gives us, if we find something when we start tracking these patients and it is a significant safety issue, we have the ability pretty much overnight to stop the use, slow down, send the data to the FDA, do some further analysis, and really decide what's going on before we see any additional patient harm. And again, I think that makes our system very unique compared to other systems. Next slide, please. So where are the gaps? Because I feel like I've described the VA as the utopia, and that's not really the case. I think we have some of the same struggles and gaps that a lot of healthcare systems do related to this class. One thing that was identified very early on is that we needed a standard operating procedure, at least nationally, that has core elements and then can be tailored at the local facility level. We are the largest healthcare system in the country, but within our system, we have facilities with different capabilities, different infrastructures. And so it's important, if we give the bare bones of this is what you need nationally, the facility can tailor that based on what their facility capability is. And this is where I think we really could use help from this committee or from other groups that are looking at this, because I don't think we're the only institution struggling with this. But we need to make sure there's the appropriate infrastructure to assure safe infusion of the drug. So dedicated infusion space, monitoring space. We need providers, nursing staff, et cetera, who are educated on these drugs and the risks and how to appropriately infuse. We've recognized that there's variability across the system in terms of access to ongoing testing and monitoring. So I just listed some of those tests here, and this is actually what we require at the baseline. We've worked with our groups internally to try to identify where the capabilities for these tests exist and where facilities have contracts in place. But I think, again, as a whole, in the U.S. as a medical community, this is an area where we could really benefit from support and guidance outside of our system as well, because I don't think we're the only ones struggling with this. We've also identified that access to providers is a gap. I don't have it on the slide, but I would be remiss to not mention that there is generally there aren't enough dementia care providers who are really trained in dementia and appropriate diagnosis across our system. And I'm sure that's the case in the community as well. We also identified that there aren't enough neuroradiology providers with the right knowledge base to interpret the neuroimaging findings that we would anticipate they need to look at here. We know we have some local providers. VA is very innovative in terms of telehealth and teleradiology. And we know that we have contract providers too. So figuring out how to put that together internally, but also partner with the community is really important. We've recognized a need for centralized education and training, and really in a bunch of different areas. We don't have the training developed yet. A small portion of this, specifically related to the drug, would come from my office and pharmacy benefits management services. Some would come from other sections of VA. And again, I assume that this is a gap in the community too. So we're hoping that groups like NAPA really can help be innovative in this space and help us bridge the gaps. But we recognize that there is a need for education and training around the drug itself, how to appropriately infuse. We need our providers to have an understanding of the appropriate baseline and ongoing screening and monitoring, because that will be really important to assure safety. We also need to make sure that we have providers that are comfortable with interpretation of imaging and lab tests. And finally, this one is very specific to my institution, but we've developed this wonderful prospective medication use evaluation that's mandatory to complete. We need to make sure that our providers are aware, that they know how to complete it, that they know where to go if they have any questions. And so I think that one is probably VA specific, but really everything else on this slide is not just a gap with our system, I'm imagining. It's something that I think that other healthcare systems are really struggling with and could benefit from some outside support on. So with that, I think that's my last slide. So thank you for asking me to present today and for your attention.
Ask them, but maybe just to clarify, I think there have been some questions. So again, with each of these processes, there are some gray zones where there have to be, I think Dr. Barafio, you talked about, what's different biomarkers, for example, validate versus reasonably likely. It's within CMS, trying to get information on what is clinically meaningful or other, what are some other parameters that we, and then within the VA too, seeking out input to fill in the gaps. I don't know if each of the agency members could speak to how do you address these gray zones and how do you kind of, so that they become clearer over time. I think you addressed it a little bit with the public comment input, the stakeholder input. I think you want to address that and ask them. But maybe just to clarify, I think there have been some questions. So again, with each of these processes, there are some gray zones where there have to be, I think Dr. Barafio, you talked about, what's different biomarkers, for example, validate versus reasonably likely. It's within CMS, trying to get information on what is clinically meaningful or other, what are some other parameters that we, and then within the VA too, seeking out input to fill in the gaps. I don't know if each of the agency members could speak to how do you address these gray zones and how do you kind of, so that they become clearer over time. I think you addressed it a little bit with the public comment input, the stakeholder input. I think you want to address that.
So this is Sherry Lane. I can start and maybe Joe can add, and it has to do with, clinical utility. I think the crux of the matter is having the evidence to really delineate what the risks and benefits are of, treatments and services, but importantly, for whom. It is entirely possible that risks would be borne out by a subset of patients that may not be the same as the benefits that are borne out. So I think if we have clarity on, that data, those data from a clinical perspective, I think it will help enable those important conversations for decision making. Right? What does this mean what does the disease mean for me in the context of who I am, what else I have, and also what the risks and benefits might be in considering, is this the right intervention for me? Are there other interventions that might be considered not necessarily as alternatives, but at the same time, perhaps? So, I think hopefully that helps address one of the questions. And Joe, I think you've dialed in now. So if you wanted to add or say something different, thank you. Over.
Thank you, Sherry. I think that's really good.
Dr. Baracchio or Dr. Martin, do you have any other comments? And I know you both addressed this to some extent, but so for Dr. Baracchio, how do you address where there are gray zones in like either the biomarkers not being as, the fully validated ones, or how did your group address that and some of these gray zones? And then with the VA, I think, again, some of the criteria for use, and there may be some gray zones that need to be refined.
Hi, this is Teresa Baracchio. So, as I mentioned in one of the slides on accelerated approval, is that we do allow some degree of uncertainty in our evaluation. So, for accelerated approval, just the benefit of having a reasonably likely surrogate endpoint, we allow for some uncertainty in that. It's hard to quantify what level of uncertainty we would allow, but it really depends on the scientific support for the proposal and the unmet need that's available. So, I do recognize that we at the FDA have a little bit more ability to allow for uncertainty than perhaps CMS does. And so there are just some different standards. And I think, certainly the size, CMS has to consider other things that we don't necessarily have to consider, like cost.
And this is Jennifer from the VA. I mean, we recognize there are a lot of gray zones. I think what Teresa just said really stands for us. We recognize there are things we don't know that we may learn over time as more data evolves, but that was one of the reasons that our criteria so closely mirror the existing data that we have. And that was really the impetus for us to do the data collection. We recognize our patients are somewhat distinct from patients in the private sector, being that they tend to have more medical comorbidities, more polypharmacy. I think even when you compare them to the general CMS population. And so for us, doing that internal data collection, especially when there's a gray area, really helps us to make informed decisions for the patients that we support.
Joe, did you want to address the cost issue as far as CMS considering cost in the decisions?
Sure. So yes, on that, for our traditional Medicare coverage determinations, we do not consider cost of the item or service.
Thank you. So we will open it up for the panel discussion. Just a comment as we transition. Dr. Martin, I thank you. As a clinician who practices in the VA for the last 20 years running a memory clinic, I appreciated that criteria for use was circulated around. We were able to get feedback. We could see some changes in that, some tangible changes, and that it did take into account the veteran population. I do worry about some of the cut points for the cognitive tests, but hopefully we'll be able to provide feedback as we start experiencing that in clinical practice.
Yeah, definitely. Thank you.
Thank you. Oh, all right. So we'll try. I think we're going to ask some questions. Are you coming up for the next session?
Do my questions right.
Yeah, you can do your question.
Great. So I'm Randy Bateman. I'm the subcommittee chair for the research committee at NAPA, and we've been deliberating quite a bit over the past several months how to move the research discovering findings and validation at the clinical trial level. How do we move from there into health impact? And one of the key things that all of us are focused on, concerned about, how do we optimize how patients benefit from scientific advances in the field? And our speakers today have done a fantastic job covering the processes of how these processes occur in the communication. The question I have to the speakers from CMS and VA, the two agencies that have spoken, that have responsibility for thinking about treatment delivery to patients, is where we know where the VA is at now, but what's not clear to me is how that might change the full FDA approval of drugs and what would occur next. And I have no idea where CMS is at right now. So I have a very specific question for the CMS presenters is, will treatments, the monoclonal antibodies, remove amyloid plaques, which scientifically, by the way, in the scientific field, the medical field, we're cheering. We think this is fantastic. We are able to remove amyloid plaques that's never been able to be done before. We're able to slow the progression of disease that able to be done before. And the question I think all of us, including medical systems that will speak later, are asking is, will these be supported and covered by payer systems, or will they be restricted? And if they will be restricted, how will they be restricted? And will they be restricted by CED? Will they be restricted by requirements for diagnostic testing or specialists? And so I think the 3 points that were covered in the presentation are very salient for provider systems, medical systems, tests, the things that we need in order to treat our patients. We have to have those things. But we're currently flying a bit in the dark, and so I'm asking for some clarity, which is what are the intent and the plan for when these drugs do get full, if and when they do get full.
Joe, did you want to start? Sorry, I'm jumping back and forth.
Mike,
The mic's working now. People in the audience online here. We're not in the mic.
Joe, can you hear us now? Thumbs up,
yeah.
thumbs down.
Yes. So I think in general, we definitely were willing and are looking for the new data and evidence that on the new drugs, in addition to really the discussion at the FDA advisory committee meeting, upcoming one, and the data from. We have been tracking those, all the data and the publications very closely. We have been in touch with the manufacturers and other stakeholders so that we can really look at the data as they are being sort of published, and really take it from that point.
I'm not sure that answers your question. The question is where the payers are at now. Currently, I guess let's talk about CMS first. So where you're currently at now, are you thinking that it's going to be a CED coverage determination for this class of antibodies if they receive full approval, or some other mechanism?
Yeah, so Joe, feel free to correct me, but, and hopefully you can hear me, but because of how the NCD is structured, if FDA gives full approval, that will permit CMS to develop broader coverage as opposed to not non-approval or just the accelerated based on surrogate indicators. So, and there's another part of this that I think is worth mentioning, right? So there is the decision itself, but there's also the question of for whom are the benefits observed as opposed to who the risks are observed in. So how, where does that information gathering, how is that proceeding in the current state as we're waiting for, the FDA decision. And the reason I ask that question in that way is because, as we have discussed in the past, we have work to do as a health system, right? To be able to let's stop just right there. Identify people with cognitive impairment and help our system to facilitate their obtaining a good diagnosis and to inform plans of care, regardless of what the treatments are. And, we see those of us who do provide care for people living with dementia, we see missed opportunities. If this were better managed early on, and it's not about any specific drug, it is about conditions that could be mitigated. And I think about, blood pressure management, the things that we're identifying in the Healthy Brain Initiative. I think even with new therapeutics, I think we still have to think about how do we optimize total care for people who are living with dementia. And by the way, also take care of the caregivers. So, all of that is rolled into the answer to your question, because I think it is, what I don't want is for this conversation to be so focused on access to a new therapeutic while foregoing opportunities to improve care overall. So, is that?
Sherry, I think it's very helpful. I agree with everything you said. It's not that I don't agree with certainly what I'm trying to get a handle on, though, is, to me, there's a risk-benefit balance for access versus restrictiveness. The question really becomes, at what level do we offer treatments that the evidence indicates that it helps these patients, changes the disease marker treatments? At what level do we offer that? And so who do we offer in terms of the restrictions versus the counterpart, which is if we say, well, we don't have evidence of this subgroup, this category of people, if we hold off treatment for those, on the CMS and the VA are calculating lost benefit of that particular restriction. How many patient years, how much dementia, how much is lost on that other side? Is that being balanced out? Is that something that the agencies consider when they make these decisions?
So I think and I'll speak for CMS, what we rely on is the evidence that is available. And so if there's evidence that answers that question, we need to know what that is, but it's not that anything that has come our way. But, I think those are important questions to answer. And also how, if you actually look at some of the work that CMS has been doing in this space and beyond, we're really trying to move towards value and team-based care to help us get there. So, this is also a practical feasibility challenge for systems where it is not one provider patient at a time. It's about how do you offer and provide the other services at the same time that could make a really meaningful difference in helping people living with dementia and their caregivers navigate the system and address, the challenges of polypharmacy and one more drug, as opposed to what is really important and meaningful. And don't misinterpret me to say that this new drug would be the one more drug. I am thinking about every opportunity we miss to re-ask the question of the 7 medications that a person has, is this necessary for this person at this time? It's not a decision for CMS to make, it's a decision for their clinicians, but how do we support that type of decision making and that type of care? And knowing what the goals of care are. So hopefully that also helps. Does that make sense? I don't know.
I think it really ties in with the theme we've talked about is it's a comprehensive model of care, and this is one part of it. And I think actually this ties into what's their hand raised next, Dr. Mend, I think has pointed out several times about even within our clinical subcommittee too, Dr. Ortega, that again, when we presented for the clinical subcommittee last time, we said there's so many issues to address still in providing good care, and this is a small part of it, and there may not be enough data yet. I know Dr. Menz, we were talking about getting, even for this meeting, about having healthcare systems that were safety net hospitals to present. We said they've got so much work to do with getting the basics done, that to do something higher level like this with all these extra steps, be no challenge. But so I don't know if you're gonna.
My comments are a little questions on the different direction. In terms of the VA, the FDA, thank you for clarifying the decision-making process. And I think that it's really important that you kind of ensure that the drug is safe. And when I look at that and I think about geriatric patients with multiple comorbidities, I would need to see safety this over a period of time. And at the American Geriatric Society meeting this past week that I attended, there was great presentations about the literature on the medications, but they were showing endpoints that were like 15 months. And I think about the patients that I serve as a geriatrician, with 54% having multiple conditions with medications with all of those. 15 months is not long enough for me to really feel comfortable that safety has adequately been addressed in that patient population. So I think safety is the number one thing from FDA, and safety for me with this patient population is a multi-comorbid patient and a much longer period of time. I'm thinking 3 to 5 years, where I would know that something is truly safe. So that was a comment for FDA. But I have a question for the VA. And this question came up yesterday while we're at Saturday when we were at the Geriatric Society. So many of our geriatric patients are on anticoagulants. A lot of them are on anticoagulants and should be on. And I didn't see that as a contraindication for your list. And when that question was asked in the room, we got different responses from the podium. So can you speak to that very common condition of anticoagulants in VA? And is that a true contraindication to proceeding with trying to use the medication? And is there adequate PET scans within the VA system to be able to do that protocol? So the VA is really where I'm focusing questions.
Okay, this is Jennifer. I have to tell you, when we reviewed this drug, we debated around that point for a significant period of time. And like you're describing, there were a lot of different opinions. And what we were trying to balance was safety based on what was in the available evidence. But we also didn't want to be so restrictive that we were cutting off access to the drug when maybe somebody would be an appropriate candidate. And, we weren't sure. So where we landed was to put untreated bleeding disorders, which, would encompass that point. And then on the lecanemab criteria for you specifically, there is a footnote that, we're not saying it's a contraindication, but it's just something that the provider should think about. And, we're letting the providers use their discretion around that point. But if it's a patient with some sort of coagulation disorder that's not being treated, those are the patients we would exclude. But I have to tell you, that was one of the most highly debated points.
And the availability of PET scans.
Yeah, I was surprised. I mean, it's most of our large 1A complexity facilities do have the PET scan capability. I actually reached out to our National Diagnostic Imaging Group, and they assured me that for those that don't, there are contracts with the community where they would be able to get the PET scans done as part of the VA benefit. So they didn't feel that was a huge barrier because there seemed to be enough between what we could do internally and what we could contract out for.
Initially, they didn't have the CSF, but I think that they did add it, because I published on it too, that they can also use CSF, which is widely available.
Yeah, that is correct. We added that for some flexibility.
And, Karen Mulkey had a question online. And sorry, anyone else answer to? Oh,
I just have a question. Whenever you're ready.
you can go ahead and I'll have Karen Mulkey a question.
I have a comment and a question. Just on that last exchange comment, that we at the Alzheimer's Association believe you optimize care by withholding coverage of treatment. And instead, it shouldn't be a singular focus. We should be able to build those things together at the same time, both comprehensive care and thinking about innovative ways of bringing diagnostic and treatment to the market. Now, to my question, Dr. Chin and Dr. Ling, thank you very much for even being able to have this conversation, certainly this forum. And we've heard a lot of information from Secretary Becerra and Administrator Brooks-LaSure recently in testimonies on Capitol Hill. One question that we have is, what evidence does it take to turn over or change or reconsider the national coverage determination moving forward?
Joe, did you want to start since it's about the reconsideration?
I'll try to provide some comment on that. I think it's difficult to say what was needed, in a hypothetical sort of situation to, as you noted, to overturn something. But I think I can mention that, in terms of a reconsideration in our Federal Register notice, we do note that for reconsideration, we look for new evidence that wasn't considered in the prior review that would potentially impact the decision. So I think from that standpoint, we know that there are a number of publications that are in process or to be published shortly that I think provides more data than in evidence what we had looked at last year.
Even the phase 3 published information that came out in November?
Right, for the two drugs.
It's not like you're wanting to know with Ganimab study.
So I'm assuming that the phase 3 was not considered enough evidence to reconsider at this time.
The FDA's approval, my understanding, it was based on the biomarker data, and then now in June it'll be based on the clinical data, which showed reduction in cognitive decline, reduction in caregiver burden, and all the clinical measures of burden. So that'll be, if I'm understanding correctly, in June it'll be considered with the FDA, that clinical data.
Yeah, I'm not talking about
but
FDA.
CMS's response to this.
Yes, correct. There was published articles since the last NCD is published that could be reconsidered, but that is not being reconsidered, is what you're saying.
You're asking CMS, is that being considered right now in the nation for coverage? The new data that's out. So FDA is reviewing it, the clinical data, but you're wondering if CMS is considering that clinical data has been published in the journal and others, that they're considering that in their deliberations, or if they're waiting for FDA's approval. I rephrase that.
Yeah, we're waiting to see, the content and the nature and the decisions that will be forthcoming through the FDA, the FDA work. So, yeah.
So that's what you're saying, that you're in process as they get information, you're reviewing that as well as that process goes along.
Well, we will take, yes, and I know that will be FDA will be looking, and Teresa, you can comment on this as well, the totality of the evidence that will be deliberated. So that's what we're.
So you're not waiting for more publications, you're waiting for FDA full approval.
We can't get ahead of the FDA, and nor would we want to, right? I mean, the safety effective.
I think it goes without saying, though, this is the accelerated approved drug that you have put through this type of review, correct? There is no other accelerated drug that has a NCD that does not provide coverage. It's fine. You're waiting for FDA, is what I'm hearing.
FDA, and keep in mind, even with the accelerated approval, there is coverage, but it's coverage with evidence development as opposed to full coverage. And
nobody's
so
received coverage through that mechanism right now.
Yeah, we are interested to know, like we talk about, health systems and how do we facilitate gathering information, making information and access to clinical trials and also care in general. How do we improve on that so that it is more equitable as well as meeting the evidentiary needs? In our prep, we did also ask the question, so those who are running clinical trials, and I think we're going to get to that this afternoon, how do we facilitate the translation into clinical populations, some of whom may have started in a trial, some who may be interested in a trial, but actually are beyond the walls of a trial. So just thinking about how we facilitate that information collection. But the bottom line is, yes, we're waiting for the deliberations at FDA role.
This afternoon's goal really is exactly, Sherry, as you described, is to try to understand how the research side of things, the understanding of the learning part of it, how does that incorporate the delivery part of it? How do we deliver care at the same time as learn? And then ideally optimize both so that care is maximized to have health impact while our learning is maximized. I think the concern for some groups, and I know my own medical system is this way, they are waiting. They are not going to take any action until CMS makes a decision. And so the consideration here is all these things interact. Healthcare delivery interacts with research, it interacts with research, evidence gathering. And this is why it's good for us to discuss this. It's going to help us to think about what we can do for each other. So what can we do on the medical health side, the healthcare systems, patients, doing research, following people over time to gather additional evidence of what might be at the same time as how do we optimize decisions, maximize the health impact for patients. And that's where these questions are coming from is how are decisions being made by the payers, groups that are delivering care, CMS, VA, and others. How are those decisions being made in the background of all these other activities? We have some time scheduled at the end of the day for this discussion, and I think it's great if after the other groups we have medical health systems and other groups to be presenting. It'd be great if we kind of circle back around to this topic, think about what can we do together, optimize each of our responsibilities in delivering care. And I just want to add that I know that everyone of the groups represented here today have been working incredibly hard over many decades to make sure that the best benefit is delivered to patients. And I think it's remarkable after all of this time, we now are at a stage where we can actually reach out. We shouldn't lose sight of the fact that NAPA is now 10 years plus, I guess 1 years this year, and the goals of NAPA are now within reach. And so we are at a place where we can really make an enormous difference, and that's different than it ever has been. Throughout all of human history, we've never been able to touch this disease.
So we're going to hammer out a lot of this stuff, I'm sure, to get it working right. But in the meantime, let's not lose sight of the fact that we're in a really good position to do a lot of good.
I think Dr. Bateman's point is important in that having these discussions here, again, as researchers, when we hear that there need to be more clinically relevant outcomes included in clinical trials to help the FDA move things along, or if we need to make sure that the patients enrolled in our studies are messier and have these comorbid conditions, like you said, that 50% of our Alzheimer's patients have, so that we can see that it's valuable to them, even if these patients. All these kind of cross conversations are helpful. We're going to go to Carrie Mulkey had a really important point that touches on an issue related to medications, health equity. So Carrie, do you want to unmute and ask your question about the use of these medications and health equity?
Yeah, good afternoon. Can you hear me okay? Great. Thanks for saying that my question was important, because after listening to the discussion, I feel like my question is less important. But did want to just continue to make the point that, so first of all, I personally really appreciate the opportunity to hear about the different processes and regulations and standards and people that are involved from the various agencies that are making these decisions. So completely understand that. I worked in government as well, and so I really understand that. However, I'm having a hard time getting past the disparities, though, that are created by these differences. So I'm just curious to know how the various agencies are collaborating to address these disparities collectively now and going forward as new evidence comes to be.
Health equity to get these therapies out to in rural areas, urban areas, just mistrust of healthcare services. We're not diagnosed. We're not diagnosed.
Limited access. We can bring up lots of challenges.
Any Dr. Bracchio or Dr. Chin or Bruce.
I'm going to go out on a limb a little bit just to share my perspective on this. And I'll say here I'm speaking for myself, not for Indian Health Service. We won't be in a position of gatekeeping medications per se, but we can facilitate the use of, certainly tribal programs operate independently and can gain and make their own policy decisions. And even on the IHS side, there is a non-formulary process for getting it. Even if these medications aren't core formulary for IHS, there's a non-formulary process. So I want to say at the outset, I don't see us as gatekeeping on the use of these medications. I do see an important role for us in facilitating the use and the uptake of these medications. But I also see a real challenge for us in ensuring that we're presenting safe and effective care for a population that has often felt that they've been experimented on, that they've received care that wasn't standard. So there's a couple of problems in our care that we try to balance. One is access, so that folks are not for a community, for a population that has had overt care rationing, that we're not rationing care, that we're providing open access to care, to the best care available. But there's the second sort of countervailing pressure, which is to say folks who have been, who've been more valued in the past as a subject than as the object of care, right? As subjects of experimentation or of testing, rather than as the constituent who we're there to serve. So I don't have any answers there, but all of these questions raised, I think I just really feel the complexity of introducing these therapies and of what we do to sort of facilitate access without and do it in a way that honors our obligation for safety
and for safe and effective care. I really feel that complexity in this issue.
I think we'll be addressing more of these issues this afternoon in the research session as well, but those complexities are, I think, felt across healthcare systems, especially in persons who have been, underserved and not getting the best access to care and mistrust because of prior histories. I think these are going to be really important issues across a lot of groups, but especially vulnerable populations.
I have a response to Carrie's question as well, which is that, Carrie, I think really what you're describing is part of the totality of what we are trying to do in our coordinated federal efforts across HHS and with our other partners, VA, Department of Defense, National Science Foundation. All of us collectively are trying to, at every stage of the continuum, address the challenges. You kind of raised the question of how do we ensure that different communities have equal access to the therapies. Well, we know that and this is frankly, for any therapy that's approved, right? This is not about specific medications, but this is for any, safe and effective therapy that becomes available. I think as the points Bruce raised, completely agree with. There are gaps and challenges at every stage of the continuum here, ranging from people's awareness of their own risk and engagement with healthcare providers, to screening rates, to accurate diagnosis, to time to diagnosis, to time from diagnosis to therapy. We, at least as HHS, while we can't control the entire continuum, we recognize that we have levers that we can use to try to influence elements of them. Part of what we try to do both through this advisory council and also through our national plan is to really focus all of these efforts in a coordinated way and in a way that enhances equity. To the points you make. You've heard a lot of other examples in our earlier presentations today. So for example, Dr. Hodes had mentioned, even further upstream, how we're ensuring that we also have more diverse clinician investigator workforce, how we are disseminating, you heard from NINDS, how through the Bind Your Risk campaign, we're making efforts to try to engage and enhance awareness among, historically, among populations, in particular, Black men in midlife who historically have had a higher risk related to untreated hypertension of what that risk is. So there's no one action. There are many actions. They have to happen throughout the continuum. They have to happen no matter what medication or therapy we're talking about. And I think that's something where, if anything, I think this creates an opportunity and a reason to really redouble our efforts, which we're very much committed to.
Was a good note to close on for this session. So I want to thank. Sorry. Oh, sorry. Oh, I missed. Oh, I'm sorry. We'll have two comments, and then we will move to our research session. After that, we'll have a 5-minute break after our last two comments.
Thank you. Recognize me.
Sorry.
I know it's hard. I wanted to kind of piggyback a little bit of what Gary just mentioned about health equity, but I also want to raise it in terms of non-technical population. We've been working on a sidebar issue in terms of the prescribing criteria that states use. I don't know if you drill down into the state's criteria, but they vary a lot. If you go online and you look at what they're saying in terms of how they want to assess individuals, describe some of the criteria to eligibility for medications. And one of the issues comes up in terms of people, for example, with Down syndrome or intellectual disabilities, the measures that are oftentimes defined as being eligible to define whether the disease is present or the manifestations of the disease is present don't apply well to populations that don't test well in the normal population. And what we would like to, recommend, and for one reason being that there's a latency between accessing medications once they are proven safe and applicable to people with neurological conditions to be able to access them. That's at this point, there's no access in terms of population. And if and when the criteria are altered and the safety studies are done, it will be years. It'll almost be half a generation before individuals with significant intellectual disability will be able to access them. So we would like to maybe suggest that we jump the gun a little bit here and try to provide some alternative criteria that apply to special populations. So I think we built into the formularies safe them. And I don't know if CMS has intentions to try to standardize the formularies across the states, but they're very a lot in terms of what they pick and choose from the clinical trials in terms of how they define the eligibility issues. So we would recommend that there be a recognition that there should be some adaptation to some of the criteria to allow people who have different ways of being tested and assessed for the presence of dementia, early MCI, early stage Alzheimer's disease, particularly those that have high amyloid risk, like Down syndrome, to be part of the process and start thinking about it now, so that when it is treated through the safety studies, clinical trials, et cetera, so they are in the process. It's not held back by a number of years because it takes a couple of years for the states to reformulate the criteria. That's sort of the message I'm trying to throw out here. I don't know if the CMS has an issue or a question or a response to that. It's something to throw into the hopper.
Yeah, I would love to understand that variability more.
We have an international working group that's trying to work this up, and we'll be sharing a paper with you shortly.
Just to follow up, and I think you know well, maybe perhaps not everyone, the critical need to have established a research base for this very important issue has over the past years led to, I think, establishment of a longitudinal study of Alzheimer's risk in Down syndrome, very much like the canonical Diane trial was. So we have longitudinal studies in place as a vehicle for trying to find what cognitive measures are most effective, even got to the point of using these as clinical trials networks. So the first couple of clinical trials for Alzheimer's in the context of Down syndrome and their high risk are in place. So hopefully we'll have our research anticipating this need and informing the process, just reinforcing what you've said. We need to accelerate it, but also by providing the information to do so.
And I just want to point out that a number of the researchers that you're citing are part of this development process. They've been part of the trials, and they're experts in the diagnosis of Alzheimer's disease, people with Down syndrome, and the instruments to be used. So, we're prepared to provide you with some information on this once we're through, getting a consensus document.
That's one little thing. NIH also has an effort underway to incorporate historically underserved populations into research better. And this whole discussion about treatments for Alzheimer's disease has really underscored the need to incorporate people with disabilities as a core focus. And there have been subcommittees and recommendations to the director. So know that you're being heard, and the department is working on that, exactly this issue.
Great, thank you.
Thank you, Matt. Your work's been amazing in trying to help bring this issue to the forefront.
I'll be quick. I don't want to delay break, but just it's a great conversation, and it's complicated, right? And I just wanted to put it in the context of we know it takes 7 years for scientific discoveries to get into practice, right? So we don't do a good job not only for this but across the board. And sort of, just listening to the comments that have been made, sort of the need for real world evidence, like the difference between, efficacy and effectiveness. So how does it work in people, with multiple conditions? How does, with different, demographics, what are the long-term outcomes? The need for, post-market surveillance. But then there's this whole, implementation science. How do we implement effectively? How do we scale and spread? And even effective care. We know we're not giving effective care right now. There's so much we know about how to care for people with dementia. We heard all those models this morning, and we haven't scaled the system. And then just finally, the whole move to person-centered care. So how do we make an integrated plan for somebody who has multiple issues, has a life, and incorporate so that they get the best possible outcome for themselves? So it's, this is a contentious discussion, but it's not that different from what we do as we get discoveries across multiple things.
Thank you, everyone, for your comments.
I know you're if not, I'll have just probably
second follow-up. We're gonna go to
just somebody a little bit of disease. I know there's a lot of issues and a lot of complications You want to get the system right, but just don't lose sight of the fact that it doesn't need to be perfect in order to get to us, because, you know, we're seeing changes in our lives every day. I can give you examples of how by the time you guys decide on this, I'm not going to be eligible, but my friends have been eligible. And we can't pay for these diseases because, you know, they're expensive. I retired early. I can't afford my own family's saving for retirement. So just don't make perfection get in the way of getting these treatments that we know are effective to us as quickly as reasonably possible, and work out the details as you're going along. And yeah, there are going to be bumps and hurdles, but man, oh man, you're talking about 2,000 people a day. That's hundreds of thousands of people a year. They're going to be waiting for you guys to get something in place. That's a lot of people. And it could be your family. I'm sorry, but I think we have the ability to do something. Let's not make perfection get in our way. So sorry, but I just want that.
That's an extremely important comment. Thank you for.
Produced by the U.S. Department of Health and Human Services.